Good morning, everybody. Welcome and thank you for joining us for the Preventing Adverse Drug Events Utilizing Medication Reconciliation webinar. I am Katie Fadenhauer, Education Manager for IHC. Before we get started today, I want to walk through a few brief housekeeping items. Attendees on this webinar are automatically muted. However, we highly encourage you to interact and ask questions during the event using the chat box function, which can be accessed by clicking the chat button at the bottom of your screen, circled here. Before entering a question into the chat box, please be sure to select Send to Panelists and Attendees, so all attendees can see the questions. We have staff members monitoring the chat box at all times. Today's webinar will be recorded. Information will be sent out in a follow-up email on how to access the recording and slides from today's presentation. You will also receive a link to complete a brief online evaluation of today's program. Please take a few minutes to complete this evaluation. It is now my pleasure to introduce Matt Pitlick. Matt is the Medication Management Lead here at the Iowa Healthcare Collaborative. He is a 2008 graduate of the Drake University College of Pharmacy and Health Sciences and completed a PGY1 residency with the VA St. Louis Healthcare System. Following his residency, he was an associate professor of pharmacy practice from 2009 to 2017 and practiced at the VA St. Louis Healthcare System in primary care clinics. Dr. Pitlick returned to Des Moines in July of 2017 as a medication therapy management consultant. He most recently completed an executive fellowship in associates in management with the Iowa Pharmacy Association. Dr. Pitlick has spent significant time practicing, researching, teaching, and serving the profession. Welcome, Matt.
Great, thanks, Katie. Appreciate that nice intro. And like Katie said, feel free to put anything in the chat box anytime. You guys ask questions as we're going throughout. If you want to say something or have something that you'd like to offer, just put that in the text box and I'll try to unmute your line as we go along as well, too. But a little bit, my background was medication reconciliation. At the VA, we worked on a transitions of care clinic, and that was a big process, a big event. And then we also, when I moved back to Des Moines, worked for a consulting company. We worked on MTM and comprehensive medication review. So medication reconciliation is a big part of completing that medication reconciliation in CMR. So first, let's go over the objectives. We're going to identify an adverse drug event, and we'll talk about differences in those adverse drug events. We'll describe medication reconciliation best practices. We'll engage the patient and family during the transition of care. And then we'll also utilize medication reconciliation to improve patient adherence, which is a really good time to do that. And so in outline, we'll talk just briefly about definition of adverse drug events. We're going to talk a good chunk about why medication reconciliation is important and why it's not just a pain in the butt and just something else to do, but why we should really put an emphasis on medication reconciliation. And then we'll also talk about medication reconciliation best practices, solutions to problems, and then we'll run through a couple different scenarios. I don't think we're going to solve all the medication reconciliation problems in this 1-hour presentation, but hopefully it gives you a few ideas of things to do, things to work through, and how to improve medication reconciliation at your institutions. But first, I want to run through a little story. I was lucky enough to go to the Iowa Hospital Association meeting, and a presentation about care transitions was going on a couple weeks ago. That was a great meeting. If you have a chance to go to it, I highly suggest it. It was fantastic. But during this particular presentation, there was a woman from Georgia, and she talked about her mom and that patient. She had 17 care transitions within 2 months of getting sick. And so she went from a few medications to multiple medications, multiple comorbidities at this time. And that patient, her mom, never had a medication reconciliation done during any of those care transitions. And so I thought of a few different things for this presentation to think about, for you guys to think about, is how many adverse drug events contributed to any of those care transitions. Could one of them have been prevented, a readmission, or a transition to a more acute setting? So I hope we get into that a little bit. Other things I thought about, who has the patient's most accurate medication list or best medication list? We'll talk about that during the presentation, but that's not as easy as it seems. And then also, thinking about why are we completing a medication reconciliation. And so we always want to think about why we're starting with why. Why are we doing these things? And we're doing them to prevent adverse drug events. And if we all try to get on the same page here for definitions of adverse drug events, and an adverse drug event, by definition, is harm experienced by a patient as a result of exposure to a medication. And that harm, we know, is of varying degrees. It could be minimal harmful all the way to death. There are preventable ADEs, and this is kind of what we focus on quite a bit with core measures and putting policies in place. And preventable ADEs being resulting from a medication error that reaches a patient and causes any degree of harm. So things we think about there, maybe an allergy that's documented in the electronic health record, but that medication gets ordered anyway and reaches the patient and causes harm that could have been prevented. There's also potential ADEs, medication errors that do not cause any harm, and this could be either because it was intercepted. So we take the allergy example again, it gets ordered, that medication, but the pharmacist or the nurse stops it prior to the patient getting that medication administered. Or it could be by luck, where the patient actually did take the medication, but no actual adverse drug event happened because of it. And then there's also non-preventable adverse drug events. We call those adverse drug reactions or side effects. And so those are things that you can't, you can't do anything to prevent them. So think of those as a angioedema event with an ACE inhibitor where that allergy isn't documented yet. So those things are non-preventable and hard to deal with. So remember these events, we'll talk about pieces of that throughout the presentation. And so remember, we always want to start with why. Why are we completing a medication reconciliation? Well, it's because adverse drug events are a problem, and medication reconciliation is one way to help resolve those problems. And so this data is getting a little aged now, but adverse drug events account for nearly 700,000 emergency department visits and 100,000 hospitalizations per year. And nearly 5% of hospitalized patients experience an adverse drug event. And so that's pretty significant depending on size of your institution, but almost at least one person in that, if you have a small hospital, is going to have an adverse drug event. So it's hard to really grasp how big the problem is all the time. So we've got to remember why we're doing certain things. And so why do adverse drug events occur? Oftentimes we have incomplete information, generally about those medications. And the solution to that is medication reconciliation. Other things to consider, we're going through some statistics here about medication reconciliation, why it's a problem, and then if it actually really does work to solve or help prevent ADEs. Up to 67% of patients' medication histories on admission have one or more errors, and 30 to 80% of those patients have a discrepancy between the medicines ordered in the hospital and those they were taking at home. And so from this data, what I want you to gather, right, it's a problem. Most patients are going to have some sort of discrepancy on their medication history, medication list. And the degree or the variation in how many patients have errors, it's astronomical. You can see that there's a 50% difference in studies. And so it's a really hard thing to measure when doing research to actually quantify the problem. If we look next, up to 27% of hospital prescribing errors are attributed to inaccurate or incomplete medication histories on admission. So that's a big problem there. And then the Institute of Medicine found that 50% of all medication errors and 20% of ADEs in hospitals occur to poor communication. And we will talk about communication at length a little bit later, but that's one of the more important things that I hope you take home is to enhance communication during care transitions and admissions and discharges with patients and with healthcare professionals. Other pieces, and this is in just one study in a review of 577 discharge drug summaries from this one institution. This is prior to any sort of med-rec process or discharge process with this institution, but 66% contained at least one inconsistency. You can see how many drug omissions there were, and a third of them were potentially harmful, and then 20% of all medications were unjustified. So there was no reason documented why that patient was being discharged on that medication. And then of those unjustified medications, 16% were harmful, or potentially harmful in those cases. So could have had a preventable ADE in that group of patients. This is a fairly recent study done to actually see if medication reconciliation actually decreases the risk of medication errors and adverse drug events. There is not that much research done on medication reconciliation in terms of decreasing risk, medication errors, and those outcomes thereof. We know based on theory it should happen, and we also do have a lot of evidence based on finding drug therapy problems. So we know when we do MedRec, we find drug therapy problems, but do we go the full length and make sure that we're reducing errors and improving outcomes from there? But in this study, we see those the medication reconciliation improved, reduced the risk of medication errors by 63%, that's a relative risk, and following discharge, reduced medication errors by 83%, also relative risk. And patients on more than 10 medications had a much higher risk of having a medication error, which we all know is true. Other reasons why we do medication reconciliation, of course, is because our National Patient Safety Goals tell us we have to, and Joint Commission tells us we have to. And I won't read this verbatim here for you, but it does. The National Patient Safety Goal does give some requirements for the hospitals to deliver on, but it leaves a good chunk of how and what you're doing to perform medication reconciliation up to the institution. So having a policy on the books of what medication reconciliation is to the institution is very, very important. You can see in there some of the pieces that have to be delivered upon. But there are a couple documentation pieces to show Joint Commission that you are meeting this National Patient Safety Goal or helping to improve the National Patient Safety Goal. You do need to obtain or update information on the medications that the patient is currently taking and document it in a list in a format that's useful to the institution. And then at discharge or whenever, you also need to provide the patient and or family with written information on the medications when that patient leaves. And that gives examples of what needs to be included in that list, such as the medication name, dose, route, frequency, and the purpose of that medication. And these are two things, that most hospitals are doing, and all hospitals should be doing, but it tends to be not with the end in mind and with the patient in mind, but rather just kind of trying to meet certain requirements that people are doing. And so, what do we think medication reconciliation is? And this is more to be tongue-in-cheek here, but is it just forms? It's paperwork. It's requirements that we're trying to do. It's more work to do on top of all the things that we're trying to do already. We're trying to take care of hospitals, trying to take care of patients in the hospital. Medications need to get to the patient. You got to make sure they're comfortable. All these, admission and discharge requirements to have. What else? Now I had to do this on top of everything else I'm doing, or it's more administrators telling me I have to do when they're not really in the trenches and they're not doing what I'm supposed to do, or doing what I'm doing. The electronic health record, is it a help or a hindrance to this process? Is it just a click and go, or is it actually asking the patient about the medications and seeing what they're taking and what they're not? And who's responsible for MedRec? And so if you guys can, I kind of want to see who's responsible for medication reconciliation at your institution. So if you wouldn't mind putting that in the chat box, and I'll take a look here as we go along. Okay, good. I get some nursing, physicians, pharmacists, nursing or pharmacists, lots of nursing. Okay. And a lot of that has to do, we'll talk about this, but it talks a lot about, when you're thinking of your policy or who's doing medication reconciliation, it's about staff and resources and who has the time and the ability to do it. So that usually dictates a lot of what's going on. I see a lot of nurses here, so it's good. And I forgot to mention who was all on the call. There's a good chunk of nurses, good chunk of pharmacists, quality folks, so a good mix of people. So I'm glad you all are on and listening in. But the IHI, the Institute for Healthcare Improvement, has a definition of medication reconciliation. And that's the process of identifying the most accurate list of a patient's current medicines, including name, dose, route, and comparing them to the current list in use, recognizing and documenting any discrepancies, resulting in a complete list of medications. And I don't know about you, but when I read that, that sounds like a full-time job for all the patients that are coming into your hospitals. There's a lot in there and a lot to do. The IHI also state that this process, MedRec, is patient-centered and it's team-based. So it should involve the whole team, the whole healthcare team, but really revolve around the patient, make sure the patient's at the center of it, of that process. If we break that down a little bit more into step-by-step piece, we see here taking a best possible medication history is the first step. I think this is the hardest step in the process. It's also the rate limiting step. There's a lot of different ways to go about it, which we'll talk about. But also, remember it says best possible medication history. Very rarely, and the study showed that before, is a medication history 100% accurate. So what you're trying to do is get the best possible medication history in the most efficient way to be able to take care of that patient. From that best possible medication history, we will write orders based on that medication history. We will compare regimens across those transitions, whatever those transitions may be, and we'll update lists and orders as more information becomes available. So in an ideal world, we'd get the whole medication list prior to writing any orders. How often does that happen? Very rarely. So we always try to update information and change things as we're going along in the most efficient way possible. Always want to identify and correct any discrepancies that we find. And we're going to communicate with the patient how that new regimen is different from that old regimen. And that communication piece is very, very important, as you guys know, but can be difficult, especially in the hospital when that patient's getting discharged and when MedRec or medication education within the hospital, when it's a lot of other things going on, is difficult to do. And focusing on that one specific piece is very hard, but crucial. And then lastly, communicating with the next providers or sites of care, wherever that transition is, or to the community pharmacy where that patient resides and gets their medicines from, is very important as well. And so let's talk that best possible medication history piece of that MedRec. We're going to get the appropriate medication, dose, route, frequency, formulation for all these types of different medications or oral medications that they're taking. So prescription medications, over-the-counter medications, herbals, supplements, vitamins, and anything else they can ingest orally that they perceive or is a medication. Because sometimes, when we ask patients what medications are you taking, they'll leave out the herbal products, the supplements, the vitamins, because they don't see that as medication per se, but it can affect things, other things that they're taking or things that you're trying to do in the hospital, that could have a drug interaction or something else going on that we don't know. Maybe it's making their heart failure worse, that one of the supplements they're taking has a whole bunch of sodium in it and making their heart failure worse. That's why they came in the hospital. So a proper MedRec based on that piece is very important. Other things you want to ask about or find out for that best possible medication history: vaccines, any devices they use, inhalers, infusions, which are becoming more and more common in the specialty pharmacy realm and the biologic realm. So these patients may have a once-a-year infusion of a bisphosphonate for their osteoporosis, and they kind of forget about it. It's not on their medication list, but it's still a medication that they're taking and can be impactful in the type of care that you need to deliver. Other things, topicals, creams, ointments, patients often forget about those because they use them only, as needed, PRN. Eye drops, and then the thing more and more common as of late is CBD or cannabidiol oil. I think that's something we need to start asking about in patient medication histories and getting that best possible medication history, because that can be impactful in the type of care you're getting as well, not let alone any hospital policy that you may or may not have, and that's for another day to get into. Other things to gather on that best possible medication history are allergies. Allergies can be often forgotten about or updated in the patient record. Adherence. Adherence is an important piece to medication reconciliation and medication history. It's a great time to ask about it because it's on the patient's list. Does not mean they're taking it. And so it's nice to ask about it on admission and at discharge or transition to make sure that that patient's taking the medication the way that they should be. Other things to include, and this is more of a pharmacy side piece of what during medication reconciliation. So there's a process called comprehensive medication management. And this is a newer term within the last decade that really revolves around the continual process, standard of care of managing a patient's medications, making sure they're safe and effective and there's no drug therapy problems. And I kind of think of this as a super med rec that keeps going on continuously for that patient, and it's a standard of care that that patient that is offered to that patient by usually a pharmacist is involved in that, but any healthcare professional could be involved in that process. And so I wanted to bring up the pharmacist patient care process in this piece as well, in which pharmacists collect, assess, plan, implement, and follow up with that patient regarding their medications and their medication management. And this is a process that's standardized and fairly new in the literature to help patients realize the care that they get from a pharmacist, from the community to the hospital, and anything in between that. So medication reconciliation is a piece of that pharmacist patient care process. Now let's go to pieces of that, or sources of that medication list. You guys have the slides in front of you, so you probably see this, but I want to hear from you guys. Who, and put in the chat box, who do you guys think has the most accurate medication list for a patient? Good, lots of different ones. Patient, outpatient pharmacy, primary care doc, whoever their primary care is, patients. I have some nursing homes in there. Good, lots of different answers here. So that's good, right? And so an accurate medication list comes from a lot of different places. Community pharmacy will have a decent list if that patient goes to one community pharmacy for the most part. Now, if that patient goes to multiple pharmacies or they have mail order or they're, have to get something from one pharmacy or one from another, then they're not going to have the best possible medication history, complete medication list for that patient. Outpatient EHRs, again, kind of the same thing. Does that patient go to one doc? Does the PCP have all the lists from different specialists that patient sees? Do they see do they see all their care within the one health system that uses interoperable electronic health records? And if not, then that's not going to be a great source or complete source. And these other ones here, they're not going to be complete sources. Patients may have the best list, but they may not. When I was practicing at the VA, those patients, a lot of them, they didn't know their medications. They, whatever they put in front of me or their wife put in front of them, that's what I took, and they didn't know. Health information exchanges have become more popular, as the last 10 years or so, as we're trying to get interoperable EHRs and have some information exchange or, records talk to each other. Iowa does have a health information exchange, but it's not terribly robust, and not everybody, is involved in the information exchange, especially community pharmacies, which may have a good list. They're usually not uploading that information that they have into the health information exchange or patient record for that particular patient. Another thing to think about too, payers and insurance companies may have great lists as well, because they can actually get some adherence data. Pharmacies can too, but payers and insurance companies can get basic adherence information, right? Just because a patient picks up a medication doesn't mean they're taking it or taking it correctly. But payers and insurance companies could be a piece, especially in the future, to get some of that data to help care for patients in the hospital. And this is a graphic, an overview of medication reconciliation to see kind of what I've talked about. And the one thing they're leaving out in the middle there is transition, so it just kind of went directly to discharge. But, fairly straightforward process, seemingly straightforward process, but a lot of hiccups and problems can, develop along the way. Communication issues can be key, or developing communication best practices can be very helpful within that institution to make sure that this MedRec process proceeds, seemingly simple as it does on this graphic. And with that, there's varying degrees of medication reconciliation, and a lot of it depends on your institution, what satisfies the institution requirements, what resources you have to deploy to be able to do some of these things. But there's varying degrees of it. So you can get a best possible medication history just on admission, and then hopefully that works, the same way going on discharge. But that, more along the lines of a click go and not very much education involved. But that would likely satisfy Joint Commission requirements. Other things to do, reconciliation discharge with electronically generated prescriptions or education for that patient. And then we try to move up the ladder to reconciliation being interprofessional and team-based. And there's collaboration, should put nurses in there as well, physician, pharmacist, nurses, anybody involved within that patient's care, and all having electronically generated discharge prescriptions. And then we can try to move to, kind of the ultimate rung on the ladder of having that comprehensive medication management where that patient's getting, a high-level touch medication education prior to discharge, discussing any medication changes and questions that patient may have. Involving the family with it as well can be very important. And then having additional elements within that piece as well. So having a post-discharge call, a follow-up from a nurse or from a pharmacist or from a quality folk or a care coordinator that you may have. Maybe you have a transition of care team, and these are things that they can do. And then what can be hugely important or hugely impactful to help prevent readmissions or any adverse drug events post-discharge is communicate any medication changes in that hospital stay directly with both the community pharmacy and with the primary care physician or primary care provider for that patient. We try to move towards this way, but again, a lot of it depends on the type of resources that you have for medication reconciliation, what kind of program you want to put in place. Important things to remember with medication reconciliation, the type of errors that can happen just with medication reconciliation. There can be omissions, so that's where meds that the patient should be on are not added to the hospital list. They were omitted from it. Or commissions or additions where that medication is added to the medication list that the patient should not be on. So maybe it's an insulin dose that got reduced, but you still have the same insulin dose from a year ago, but that patient's been losing weight and trying to really control their diabetes. And so an ADR can happen, or an ADE can happen there with that particular error on medication reconciliation. You see there's a few other errors that can happen that you want to categorize. If you want to really take a deep dive into your medication reconciliation process, you can categorize the types of errors that are often seen, and you can put in place strategies to try to improve whatever error is most common. Other things that can happen too are substitutions and formulary issues. So you may have a formulary for your hospital, and trying to figure out the formulary for your hospital, and then when that patient is discharged, figuring out that formulary issue on the patient's insurance side of what's covered, what's not. And so for the vast majority, omissions are the most common error that's going to happen based off of studies. And so things to think about there when you're developing your process or trying to put strategy in place to improve medication reconciliation in your institution. Now let's talk about best practices for a little bit. This comes a lot, I'll share the resources that I've utilized in the past, but a lot of best practices out there with a few different groups. And one of the main things that really comes out of it is having an oversight team and a flow chart of the medication reconciliation process is hugely important. So you have to have somebody ultimately responsible for medication reconciliation. Not necessarily doing the med rec, that goes to your nurses or pharmacists, but having that oversight team, so it might be your quality folks out there, or a chief nursing officer, your pharmacy director, being on that oversight team, but having it team-based and having good input, and then making a flow chart of that process. And then you have to make it a priority if you're trying to improve. And if you have a good process, that's great. You should get it out there and let other people know about it. But if not, you want to make it a priority, and you have to make it a part of 1 to 2 major goals that you can really impact the institution. And so also at that hospital association meeting, there was a great keynote speaker talking about how you execute change and make things happen. And the way you do that, think about it, if you have 1 to 2 goals, you can really put resources and time into achieving those goals. If you have 20 goals, it's really hard to achieve all those 20 goals, and likely you won't. And so really make it a focus of 1 to 2 major goals. And so maybe you really want to focus on readmissions. You want to improve readmissions at your institution. And medication reconciliation is going to be a part of that strategy. And so you make it a priority of whatever goals you have set, strategic plans that you may have. The data is also pretty clear on this, is that if you put a pharmacist or nurse in charge of that process, that is the ideal scenario. No reasons why that were given, but these folks, they have they have the time, they have the knowledge, and the wherewithal to really put in the process in place and try to execute that change that is needed to make the process better. And if you have to redesign the process, you definitely need to change what's not working. You don't want to keep making the same mistakes over and over again, or the same errors over and over again. So that's why it's good to do a little test or see what the errors are that are occurring within your institution, and redesign the process. Don't be married to it, but make swift changes to help the efficiency. You also, if you're not have a running med-rec program, or trying to make improvements, on it, phase it in. You don't want to make a humongous change at your institution all at once. That's going to be really difficult to do. So maybe you want to focus on the emergency department and really want to get down the med-rec process at the emergency department to phase it in, to make a sample project that you can really get it out, because the emergency department is going to be a really important piece in med-rec and med-rec improvement. Or maybe you want to focus on those high-risk patients, patients on 10 or 15 more medications, or they're on high-risk medications, anticoagulation, diabetes medicines, and you want to focus on that. So phase it in with different pieces, and then you can adjust and then deploy that to your institutions once you kind of work out the kinks for it. Other things to think about: work with your EHR vendors. There are programs and things out there that can help. I'm not in tune to all of them, but there are things out there that can really improve and help the med-rec process via technology. And trying to be as proactive as possible and trying to do the med-rec prior to any orders is really, really important. Not only for you doing the med-rec, but for the whole healthcare team and the patient, to make sure that patient's getting the best orders and the best care taken care of. I'm looking here, there's a question got coming in. How should physicians be trained on medication reconciliation? Is there a good training resource using peer-to-peer information on medication reconciliation? And should the physician have responsibility in deciding what medications the patient is taking? And absolutely, the physician absolutely needs to be involved in the medication reconciliation process, of course. And the physician will ultimately be responsible for ordering those medications, unless there's some sort of collaborative practice agreement that you have, or whoever that primary person is writing the orders is ultimately responsible for those medications that the patient is taking. There are some training resources out there. They're not necessarily provided directly at physicians. There are some older resources out there from the AMA about med-rec and the physician's role within med-rec. Those are fairly old, though. The resources that I have for you, they're multidisciplinary and can be utilized with everybody. But great question on that. Of course, we want the physician involved in the process. Other best practices, we kind of talked about starting the process before before the patient arrives. That's why the emergency department piece is so important, of doing the med rec in the emergency department prior to getting to the floor or wherever else that patient's going to be going. One thing to do, and this is hard, I realize that, is separating the med rec process from any admitting and discharging tasks that may be going on. You want to think about it as a separate process and not really as just a checkbox to get done for that admitting and discharge, or for that admission and for that discharge. That way you can think about the med rec and getting that best possible medication history outside of all the other things that you have to do, and focus on that one piece, which can be impactful not only during the admission but also discharge and then consequently readmissions. You want to try and be as consistent as possible and standardize your documentation. AHRQ or ARC, they have some great resources out there for documentation and standardizing that you can utilize within your electronic health record. And if you guys have something that you've been using, great. I would highly suggest sharing that with other folks that you think is a good documentation to help with MedRec. Other medication things, be wary of sound-alike, look-alike meds and any abbreviations that you may have. If it's coming from a patient's personal medication list, they may have some abbreviations that you may not know or you may not have heard of, and because they're not real, just the way the patient remembers the medication. Or if you're getting a verbal list, that can be hard too. I can barely say the names of some drugs anymore, new ones that are coming out. So it's hard to get that list if you're taking it verbally or just from a paper list that the patient may have given you. Other things to do: report and learn from any errors that may have. So it's, do your tests and your studies and learn from what's going on and from those errors. That way you can improve. And it's important to have a culture at your institution where reporting those things and really trying to improve is not looked down upon, but is highly encouraged. And then also focusing on communication, like I've harped on. The communication breakdown is where most of the problems are going to occur, either from the patient to the nurse or to the pharmacist or to the physician, and then back to the patient, or communicating that discharge to the PCP or to the pharmacy, or on admission too, from if you're trying to call community pharmacy to get for admission medications, or from the electronic health record, or from the PCP. And you also want to educate and involve patients and their families. And there's a few different ways to do this, and that's difficult, especially at discharge, when really a patient, all they want to do is just leave. And you got to say, no, just wait. We have to really go through this stuff and educate you, so that way you don't have to come back. And usually patients will listen up on that at that point. But really encourage that patient to be proactive and try to let them know that we're trying to do everything that we can to keep you in mind and keep you out of the hospital, and so you can don't have to come back in for the same issue or have a adverse drug event that can happen. You always want to have the patient keep an up-to-date list of medications on them electronically, whether they have a electronic record, personal electronic health record for themselves, or via paper. You want to have that patient or have a family member present if possible as well. Spouse or whoever their caretaker may be would be really, really important. And things to think about as well is health literacy. How well does that patient actually know their medications and say their medications, know what you're talking about? Do they know what twice a day means versus every 12 hours? They may think twice a day is, if I take it at 11 a.m. and 2 p.m., that's good, but really that medication should be taken every 12 hours. And so that, you want to really gauge that health literacy. And there's different tools out there to gauge health literacy for patients. And we talked about families, teaching them together, and having patients be involved in their care and making shared decisions in their medications. And so maybe that patient won't take warfarin, for example, for whatever they heard on the in the internet it was rat poison, and they're not going to take it. But you never really asked, and we never really talked about it with the patient. But they know when they go home they're not taking the warfarin, and they need something for anticoagulation. And so those kinds of questions and having patients involved in their medications and in their care is very, very important. That's how we talk about adherence and make sure that the patient's going to take their medications. And so from that, you want to approach patients without any preconceptions or have any assumptions of what they're going to take, what they're going to do, what they're going to take when they go home. A couple other questions coming in here. Should there be a hard stop in the EHR for the physician to approve or verify the med reconciliation? Hard stops are difficult to gauge, especially when you're taking care of a patient that is in an emergency situation, or they need stuff soon, depending on what it is. So hard stops, that's something that I think you have to discuss with your institution, and whether or not the care team is comfortable with those hard stops. May not be, and I think just having a discussion with physician, pharmacist, nurse, any committees that you may have, quality folks, that would be important for ordering those medications. So no real 100% guidance on that one, but again, have a discussion. And other things too, got a quite good tip coming in here for getting medications, having photographs of the medication labels saved to a smartphone or using a smartphone app for medications, which there's a ton of them out there now, can be great when patients need to share their medication list with you. Great tips out there, thank you. Another thing to think about, and this is more for that quality team when you're discussing medication reconciliation, is having best practice questions. You guys can read those. I'm not going to get into everything there specifically, but having defined roles and responsibilities is very important. You want to have somebody responsible for MedRec and have defining roles. So is the pharmacist responsible? Is the physician responsible? Or what is their role within medication reconciliation? And that will come in that flow chart that you develop. You want to have policies and procedures in place of when a MedRec is completed. What is MedRec at your institution and when is it completed? It can be any of those varying degrees of MedRec that we talked about. That likely would suffice Joint Commission requirements. But you want to make sure you're taking care of the patient and making sure you're getting the best possible medication history along with it. And then also, do you have a process in place not only to determine whether MedRec is being followed, is the process being followed, and then how well is that MedRec being done as well? Do you have a process in place to evaluate how it's being done? And you can often, work with colleges of pharmacy. They're often looking at, how to get scholarship and studies going, and this is a great place to do that. You can ask for assistance in that place to see how well your MedRec is being completed. And then, does the facility have strategies in place to redesign and determine if are there any barriers to the medication reconciliation process at your institution? Good questions to ask when you're developing that MedRec team. And so, like I said, it sounds easy, it sounds simple, straightforward, but why is MedRec so hard? And a lot of times it's because there are unclear roles and responsibilities. It's a team effort, but we haven't defined those roles and responsibilities within the institution. And maybe we have ideas, or you guys have ideas of how it can be improved, but you need to get it out there and let those people know, or let the quality team know, or let the MedRec team know how things can be improved. Other things, and we all know this, especially in this climate that we're in right now, it's staff, time, and resources. And we can't do everything all at once. And we got to deploy our resources and our staff and our time to where we really have the best return on investment. And as we're evolving from a fee-for-service environment to a value-based environment, I think MedRec is going to be becoming more and more important when reimbursements are improved, when patients are staying out of the hospital, you're not having readmissions, or you're not having ADRs while that patient's in the hospital. So doing a MedRec at that time is going to be incredibly impactful as we move along to value-based care. And we talked about the information gaps. The sources of the best possible medication list are seemingly endless. We had that slide, but I don't think that's an exhaustive list of where all of where you can get a medication history from. But the gaps exist everywhere, and trying to take the time to call every single pharmacy, every single provider, is not realistic in most cases. And we're also, we're relying on the EHR to do a lot of the work for us. And so if we don't have an understanding or there's variability in the performance within the EHRs, depending on the EHR you have, it might not be that easy to get a great medication history, or it might not be interoperable with the emergency department to the floor or from outpatient to inpatient, even though you might be in the same institution. So it's really important to get into the EHR, think about what it can do or ask questions about what it can do. And that's not just a click and go. It's there's some thought process to it, and you're actually making sure that the medications for that patient are appropriate. Other pieces is not easily, MedRec itself is hard to measure. There are different ways to measure it and monitor that we discussed. So, some things are readmissions and length of stay and emergency department visits. We can also get medication-related problems at the time of MedRec. Did they happen or were they resolved? We can get disease-specific metrics. We can get patient satisfaction scores. We can also look at our HIN ADE measures that I know you guys are all familiar with and getting. And so we can look and see if those ADE rates are going, are improving, or any medication-specific ADE is improving that we measure. Got a question coming in here. Should discharge orders from a patient that was in acute care be the new home med list in a skilled unit? We're having concerns with this process as all previous home meds are not addressed. Yeah, and so that is a question, I think, for your institution, and what defines a medication reconciliation per your policy. And so I guess what I would say is it depends. I would say not all medications, if they're not taking it, should obviously be in that skilled unit, but you want to make sure, based on that transition, what the patient medications transition from acute to the skilled unit is important. And also, coming from the home, if not all meds are addressed, something could occur. Of course, there's an omission error there. So maybe that patient needs X medication, but they're not on it when they're admitted or when they're back to that skilled unit. And so maybe what I'm thinking of here is maybe something like metformin, where you're going to hold that inpatient most likely if that patient needs any imaging done, if they're getting contrast dye, whatnot, and then they probably should be on it at the skilled unit, but it didn't get added back to the list. And so in an ideal world, of course, you want 100% looked at home to inpatient to acute to skilled unit to step down to home again. And so that's the ideal world. Is that what's going to happen in a lot of cases? Probably not, but we try to get that best possible medication history going along. We've talked about barriers to MedRec, so I won't belabor this, but having open mind to change, I think, is the most important thing. And not rapidly implementing any change or having too big of a change is important. And so let's see if we got any other questions coming in. Seems like intra-facility transfers could have strong MedRec processes with pharmacist nursing communication. So yeah, and so if you have a intra-facility, one facility moving from ICU to floor, or same institution to a skilled facility, having communication with pharmacists and with nurses is very important within that. Very good. So let's do one of these scenarios. This isn't meant to be, testing or going along, but just an example of kind of the process that we're going along. And so this is, a 7-year-old patient presenting to the ED, chest pain and acute kidney injury. You see the past medical history there, and the med list on the right. And we'll move here. A couple questions. What clarifications would you have for this med list? And then what orders entered, if you went just with this list, what order could lead to an ADE? And just pop those in your chat box. And this is how the patient's list looks to you when you get it. So that line through the lisinopril is supposed to be there. There we go. Plavix with Xarelto, very good. Aspirin, tramadol, Lantus doses, we don't have a dose. Very good. So are they on lisinopril or are they off? Very good. Lots of good stuff there, of course. And what could lead to an ADE? What kinds of ADEs could happen? Better question. Like a bleed, very good. Drug interactions, anti-coag, and maybe some, we don't know renal failure, what's going on with that. So maybe the Xarelto dose is a little too high, metformin, hold, whatnot. Very good. And so MedRec's completed. We don't know how well. We're going to hold the metformin while the patient is in-house. We'll start Novolog 5 units with meals, and we'll replace Xarelto with Eliquis. So that's the current med list that the patient's on. And then as we're doing a discharge MedRec, this is the list that you got. And so what questions would you have or concerns about this med list? What does PRN mean? Very good. So maybe the patient doesn't know what PRN means. Metformin not restarted. Very good. So maybe that's a question, should we not? Insulin. We got a duplication. We got a atorvastatin and Lipitor on there. So yes, lots of good stuff on there, guys. So these are the kinds of things you think about. Norco, we got a range. And that's one thing to think about too. If we go back, that Norco wasn't on the patient's list while inpatient, so why are we sending them out on an opioid as well? So things to think about there. Very good, guys. Next scenario, this one's not exhaustive. This is just a small case, but you got a rural patient, diabetes, dyslipidemia, hypertension, gout, depression, AFib. Autofill to VA is where they get bulk of their medications, but they also use a local independent and a large chain. Their care providers, they have a VA provider to get meds from, a local PCP that takes care of them as well. They have a cardiologist and an endocrinologist in the city that they have to go to, and they're admitted to a rural access hospital for new onset heart failure. How would you guys go about completing this MedRec? That's the question right there. So you guys can put them in the chat box, but I'll keep going along with time. But in this type of scenario, you're really gonna have to use every tool in the toolbox. Multiple EHRs, you're gonna have to call from, multiple medications, multiple pharmacies, and this is gonna be a team effort. It's tough to reach out to all of them, so you're gonna try to get the best possible medication history. It's not gonna be perfect. This, you might have to rely on the patient as much as possible, or the patient's list to get that best possible list. But this is a common scenario. This was kind of my world when I was practicing at the VA, and we started this medication reconciliation transition of care clinic. I was trying to get all these medication lists, and so that was just a clinic devoted specifically to that. And I know you guys can't do that. So if you have when you're charting out your process or putting your flow chart in place, think about these really time-consuming scenarios and how you can be more efficient within those. Discharge and transfer education and communication, hugely important, like I've talked about. Not only to the PCP, but one of your best friends can be the community pharmacy that patient goes to. If they stick with one, that's great. But having direct communication with that community pharmacy, oftentimes the patient can get to see that pharmacist maybe a little bit sooner than the PCP or wherever their follow-up appointment is. But they can go see that pharmacy or go pick them up, or maybe you can get a partnership in place to be able to have some of that communication. Other things to think about too is beware of autofill, especially with the VA. Just because that autofill is going off and you see the patient getting their medications every 3 months, doesn't necessarily mean that the patient's taking their medication. So it's a great time to talk about medication adherence, which can also be time consuming, but seeing if that patient is actually taking their medications the right way is really important. Adherence, if patients aren't taking their medications, they're not going to work 100% of the time. And so adherence is always the rate limiting step, whether that patient's going to really get better with whatever medication plan you have in place. And things to think about with adherence too are social determinants of health. Does that patient have transportation to a pharmacy or to wherever they're getting their care from, to the doc's office, to the nurse practitioner's office? Can they afford their medications? Maybe they have to split their pills or not taking some based on affordability, or not getting the care they need because of affordability. Other things to think about, food, and are they taking care of themselves health and wellness wise? And things to think about, that I've got asked about is price checking prescriptions. Is this a good thing or a bad thing? That depending on the patient's insurance, it might not be a place for you guys, but maybe that's a thing to think about communicating back to the primary care, that community pharmacy, whenever the discharge happens, is thinking about pricing these things out and having somebody check on it for that patient. Not necessarily you guys at the time, but it's huge. So affordability, price checking, I think that's going to become it already is becoming the future, and the present of what's going on. Other opportunities for improvement. There is a service out there that Medicare pays for called transitional care management. And if you guys don't have a TCM process in place or a program in place, I'd look into it while you're trying to improve your medication reconciliation history, especially if you're part of a health system. That can be a huge tool and a great way to get ROI on the resources you're deploying for improving medication reconciliation. Other things to do too, there is actually great studies out there to show that pharmacy technicians can be utilized for medication history to get that best possible medication history. If you have a good technician that's been trained and there's quality assurance done on that medication history. But there is a new certification out there from PTCB. They're the Pharmacy Technician Certification Board, and they have a medication history certification that technicians can obtain to show that they can perform well while getting medication histories. And so really it's that first rate limiting step, that first piece in MedRec, the whole process that pharmacy technicians can do if that's an idea and an opportunity for improvement. Other things to think about, I talked EHR enhancements. It's really asking questions and what can be done within that EHR and trying to automate things as much as possible to make your lives easier, but good automation, not bad automation, to where you have to go back and redo things over and over and over again. Also with communication, I wanted to let you guys know this is a newer group. It's called CPESN Iowa. They're the Community Pharmacy Enhanced Services Network of Iowa. And that map there shows locations of those pharmacies. So a lot of times they're in rural areas. You can see it's kind of, there's a good chunk in Des Moines area and Iowa City area, but it's spread all across the state. This is a national movement in the United States to have enhanced services networks. Iowa is one of the more robust service networks that we have. Medication reconciliation is a core service that they offer. And so what those enhanced services are is not just dispensing medications. They will perform these services in addition to just dispensing medications. And you can't get that at every community pharmacy, but these community pharmacies, they abide by these services and these core services that they have. So maybe there's a potential partnership there that you guys can have or look into when you're developing your MedRec process to help. Because I know resources are tight and money's tight, and maybe they can help in this instance. They have a website there where you can see what the actual locations are, but I reached out to their director who runs the network, and she gave me story after story of times where the community pharmacy and the hospital work together to really help prevent ADEs and get that patient taken care of and get their medications either before discharge or soon after discharge. Resources, there's a good chunk out there. I won't belabor them, but they're on the slides. You guys can look them up. Probably the best ones to go to initially, the Match Toolkit is got some great stuff. That's just a big document though, so it's a lot to go through. The Marquee Implementation Toolkit, very good as well. The IHI stuff we talked about. ARC is some great stuff, and then also a how-to guide with the IHI that we talked about. So summary and closing, we talked a lot about MedRec, how it reduces ADEs at the beginning, and trying to engage the patient, trying to think of best practices and develop solutions to the problems, and really think outside the box, try to develop those innovative strategies utilizing those resources. And like I said, MedRec, I think, is only going to become more and more important to, as we move along into a value-based care environment, to make sure that there's no readmissions and things are improving for that patient. Let's see, if you guys have questions, feel free to put them in as well. One little thing I wanted to go over, this month is American Pharmacist Month, and actually this week is also American Pharmacist Week. So a big shout out to all you pharmacists out there, fellow pharmacists. We appreciate what you do. If you have not, really thank your pharmacist today. That'd be a great thing to do. Pharmacists and pharmacy technicians, they're, integral pieces to the care team and can have a lot of impact on patient care, not just dispensing medication. So thank you all for what you're doing for your institutions. I know it's a struggle out there for everybody right now, but you guys are doing great work taking care of patients. And then I'll look for any questions in the chat box now. Sure, so now see the CPESN slide again. And there are, for that network, there are about 110 pharmacies that are signed up with CPESN Iowa. You went too far. There we go. I'll wait a couple minutes here. Anything else? Sorry, we went over a little bit. Great. Well, nothing else, guys. And if you have questions, feel free to reach out anytime. My email is in the slide there, so feel free to reach out anytime. I really appreciate you guys, coming in right before lunch to listen to the presentation. Hopefully, you took away some pieces that you can take back to your institution and improve the MedRec process and take care of the patients in your communities. Really appreciate it again. Thank you very much.